Very good. All right, so at this time, everybody should be able to see me, see my slides, and we're also live. Gonna give everyone a few more minutes to sign in and log on. And while you're doing that, I'm gonna launch a little poll. So go ahead and take this poll for me while we are waiting for people to log in. We've got a few more minutes before the top of the hour. And I know everyone's joining us on their lunch break. So I appreciate your taking the time out of your day to listen to me talk about lab reviews and infectious diseases. So go ahead, if you can, take this quick little poll while we're waiting for everybody to join us. So if you haven't joined me for a webinar before, my name is Hiva. I'm one of the nurse practitioners here with Archer Review, and today's webinar will be talking about lab reviews and infectious diseases. If you've joined me before, you know that we always like to keep these webinars pretty interactive. So keep that chat box open. I'm going to be asking you some questions, and our lovely Miss Rachel is helping us in our chat box. So keep it open, ask your questions, answer questions I may ask you, but this is the time to ask those questions so that you guys get it right on the boards. And then generally, it's a lot. The topics are kind of dense, but I do like to try to keep it interactive. So if you have any questions that pop up, feel free to put it in the chat and we'll try to cover it today. All right. All right. I'm going to go ahead and close out this poll. It looks like most of you have gone ahead and answered it. I appreciate that. Thank you. And I think most of us have already logged into, so I'm going to get us started. All right, so we're going to start with lab review. The topics we're going to cover about lab review are just the basics of a CBC. We're going to go into leukemia and lymphoma a little bit, myelomas, anemias. That's going to be really important for you, both for the boards and for your clinical practice to be familiar with. And then also what happens when you see some elevated red blood cells on that CBC. So you probably have seen a complete blood count by now. You've been in your clinicals, whether you're wrapping up clinicals or getting ready to sit for your boards. You've probably seen components of a CBC, but you've seen that there's a hemoglobin, hematocrit, red blood cell, white blood cell levels, platelet levels. You're going to get really comfortable if you're not already with looking at the ranges of these values, right? So especially for hemoglobin, hematocrit, you're going to get really comfortable with looking at what's on the lower end of normal and what's on the upper end of normal so that you can identify if there's any low hemoglobin hematocrit or elevated hemoglobin hematocrit. And we'll talk about those anemias in a little bit. You're also probably going to get really familiar with quickly scanning that white blood cell count. If you get a CBC with differential, that breaks up those white blood cell counts a little bit more for you, depending on what you're looking for. But that helps you rule in and out infection, inflammation, and then also looking at your platelet count and your red blood cell count. So we're going to break those down today and talk a little bit more in depth about that. So for your white blood cell counts, neutropenia is your low white blood cell count. Leukocytosis is your high white blood cell count. So why does that matter? We're really looking at infection, right? And also to rule out cancers, inflammation. So if your white blood cell count is over 100,000, we need to promptly work them up for leukemia. So that might come up on your boards. They might say, this person give you a CBC and show you some results. And what they want to know is that you're going to investigate why that white blood cell count is so high, right? Different types of leukemia, there are four main types. So you don't have to know all four main types. What they really want you to see is, do you know what normal is and what abnormal is, and what are you going to do about it? In clinical practice, you might see that ALL is more common in childhood. So these are two different types of leukemia, acute lymphocytic leukemia. So it's more prevalent in childhood. And then there's myeloid leukemia or CML, and that's more prevalent in adulthood. So So moving on to lymphoma. So leukemia and lymphoma, they're different types of blood cancers, right? And lymphoma is when the cancer specifically affects the lymph nodes. There are two main types, Hodgkin's lymphoma and non-Hodgkin's lymphoma. And the difference between the types is the origin of the cancer cells, right? So in non-Hodgkin's, it starts in that lymphatic system. In Hodgkin's lymphoma, it starts in that lymphatic system. And in non-Hodgkin's, it starts with those white blood cell counts. They become abnormal. Hodgkin's is a little bit more rare, but it's easily treatable, and it's the lymphocytes rapidly multiply, whereas the non-Hodgkin's is more common in males, but it's a little bit more aggressive. So definitely things you're not going to be managing, but you might see on your CBC results come back on patients. So you want to make sure you don't miss it, right? And then your platelet count, we're also looking at that. Thrombocytopenia is your low platelet count. Thrombocythemia is your high platelet count. A lot of different disorders from abnormal platelet counts. You're going to be looking at that on your CBC too. But basically, we just want to make sure that we're looking for signs of infection. Is the patient having low or rapid heart rate? Any bleeding disorders coming from that platelet count being abnormal? How are they feeling, right? So all that can go into what the overall picture of what you're seeing on that platelet count coming back. And then multiple myeloma, it's cancer of the blood plasma is when it's a low platelet count with red blood cells. It is terminal, so definitely something that will be managed by a specialist. So let's get into anemias, because that's mostly going to be your bread and butter in primary care, so managing those anemias. Some terminology, so chromic refers to that color, cystic refers to that size and volume. Your MCV, you're probably really familiar with. If you're not, you want to get familiar with, because MCV holds the key. I like that saying. But your MCV, you want to know your normal values and what happens when you have a low MCV or a high MCV, right? And so low MCV below 80, so your normal value is between 80 to 100. You're going to get really comfortable with that. If you're seeing an MCV below 80, then you're seeing a microcytic anemia, right? It's micro or small. And then there are different types of microcytic anemia, so you want to figure out what type of microcytic anemia it is. So we'll talk a little bit about the labs you're going to order, but the most common is going to be iron deficiency anemia, but you want to make sure that it is iron deficiency before starting them on iron supplements, right? Because there's also thalassemia, lead intoxication, and there's a cute little acronym here for you to remember. But you want to look basically at the hemoglobin, hematocrit, the MCV, and try to figure out what type of anemia you're looking at and classify it that way so you can determine the treatment. But in iron deficiency anemia, so that's the most common. And so in that case, you're going to see, again, the MCV is going to be less than 80. Your hemoglobin and hematocrit are going to be below normal values. So you might ask your patient some questions. Maybe they came in with some complaints. They're complaining of fatigue, chronic fatigue that's not going away. They might notice some changes in their hair, skin, or nails. They might have shortness of breath. So they feel like they have to take deeper breaths. That has, that part of that shortness of breath evaluation is going to be ordering a CBC for them, but you'll be doing a lot more for that shortness of breath too, but that might be as a result of their iron deficiency anemia. And then pica, you might see pica. So in the US, you're not going to really see that eating dirt, but it's more non-food items. So that person might be craving ice. So you might ask them, like, do they frequently crave ice? Are they chewing on ice chips? That's going to be more common. So what happens when you're seeing the MCV below 80? What labs are you going to order to evaluate what type of microcytic anemia this is, right? So you definitely want to rule out any lead intoxication. It's not likely unless you live in an area where the homes still have lead paint. And if you're looking at a pediatric population, you're going to be screening these patients at regular intervals, starting at 12 months. So that's probably not going to be at the top of your differential for your adult patient population, but you definitely want to order a ferritin, because the ferritin refers to that iron storage in the person's body, and that TIBC, the total iron binding capacity, helps determine the blood's ability to transport the iron. So if the ferritin is low and the TIBC is high because it's trying to transport more iron in that blood, then that's pretty indicative of iron deficiency anemia, right? You also want to check the reticulocyte count, Reticulocytes, if you'll remember from anatomy physiology, are those immature red blood cells. So if a retic count is low, then the red blood cells are being destroyed earlier on than normal. So you want to investigate that. And then you also have your hemoglobin electrophoresis that you want to order because that'll help you sort out between thalassemia or sickle cell anemia. So when you see a low hemoglobin hematocrit, low MCV, microcytic anemia, these are the lab values that you're going to order to follow up and determine where it's coming from, what the cause is. Okay, so sickle cell anemia, you might see this in your patients. This is pretty common among a certain race and ethnicity. But basically, sickle cell trait, it's an inherited group of red blood cells that appear sickle-shaped. So remember, your red blood cells carry the oxygen to all parts of the body. So a normal red blood cell is round and flexible, so it can move easily through the blood vessels. In a sickle cell patient, their red blood cells have become rigid and sticky, so it can reduce or block the blood flow. And that blocked blood flow is what causes or could cause the crisis. So with these patients, you want to be really careful. That's over time, there is damage done to their spleen, so it raises their risk of developing infection. So you want to make sure that you're keeping these patients really healthy. You're screening them for pain and infection. They're probably going to be feeling more fatigued because they're not getting all that rich oxygenated blood. And so the primary prevention for these patients is making sure that they're staying healthy, so making sure they're getting their vaccines. And they are at increased risk for stroke, so ruling out signs of stroke if they're in a crisis, and just making sure that you're helping prevent any complications from their sickle cell anemia. So which patients are you going to be thinking about screening if they haven't already been screened or identified? So it's more prevalent in your African, Mediterranean, Middle Eastern descent. But remember, both parents have to carry the sickle cell gene and pass both copies to the child. So most likely, if they were born in this country, they could have the genetic testing done, and it would be diagnosed early on. But know that it does happen in the newborn screening in the US. But if for some reason a patient doesn't know it and you're catching it on the CBC, that again, lab test ordering that hemoglobin electrophoresis will help you determine it if you're suspecting it. So thalassemia is also inherited disorders, right? So the red blood cells don't form properly and they can't carry enough oxygen. Two main types, alpha and beta thalassemia. You might see things like slow growth and delayed puberty, and it could be a cause or a result of their thalassemia. It can also cause bone problems and large spleens. And if it's left untreated, it can lead to endocrine dysfunction or liver disease or heart failure. So definitely something we don't want to miss in our patient population. And the reason why we do that hemoglobin electrophoresis is because we do not want to give these patients iron supplements, right? So they already have an overproduction of iron in their red blood cell. So if we give them iron supplements, it can be really dangerous. So you want to make sure when you have a patient with that microcytic anemia, you are ordering these tests and you're ruling these things out so that you're not giving them something that they don't need that could cause them harm, right? And the treatment for most of these patients is going to be therapeutic phlebotomy. There's also iron chelation therapy available, folic acid supplementation. So once you identify it, then get them to the right specialist to help them with the treatment. So macrocytic anemia, going to the other side. So what happens when your MCV is over 100? So remember that normal range is 80 to 100. So what are you looking at when you're looking at macrocytic anemia? Well, so there are different types of macrocytic anemia. And again, different causes you want to investigate to see what the cause is. Could be folic acid, could be due to excessive alcohol consumption, a B12 deficiency. You want to ask your question. So they're going to have a lot of neurological symptoms. So one thing that might come up on the boards is you have a patient complaining of peripheral neuropathy. You definitely want to make sure you're checking that B12 and it's not coming from a B12 deficiency. There's also that red beefy tongue is pretty classic. Loss of vibration or proprioception, if you notice that on your exam, when you're doing your physical exam of your patient. But you're going to see some neurological symptoms. And then you want to identify the cause. There are different causes of B12 deficiency. There could come from an insufficient diet, could come from pernicious anemia, malabsorption. So if they're overweight, if they have intrinsic factor deficiency, GI issues, they've had gastric bypass. So a lot of that different causes. So you want to identify the cause and treat the underlying cause. But again, the big takeaways when you're seeing an MCV over 100, you should be thinking macrocytic anemia and those differentials. So before we jump to our next slide, I just want you guys to quickly put into the chat. So tell me the difference between microcytic anemia and macrocytic anemia, just to get a little recap. Make sure everyone's with me. Specifically, what would your MCV look like with microcytic anemia, and what would your MCV look like with macrocytic anemia? And what I always say is don't be shy. This is where we want to make the mistakes, right? Not on the boards. So again, with macrocytic, you're going to see that MCV over 100, and with micro, you're going to see that MCV less than 80. So your normal MCV is between 80 to 100. Awesome job, you guys. Okay, so going on to elevated red blood cell count. So again, on a normal CBC, you're going to see those red blood cell counts. Why do we want to look at the red blood cell count? Well, we want to make sure that we're not missing something dangerous. So an elevated red blood cell count is called an erythrocytosis. That's the medical terminology for it. There could be different causes that are not as acute and dangerous, like smoking, blood pressure medications, diuretics can elevate the red blood cell count, sleep apnea, hormone therapy, testosterone treatment. But what do we basically want to rule out and make sure it is not? Why should we not ignore an elevated red blood cell count and make sure we rule it out? You want to make sure that you rule out things like polycythemia vera. So it's rare. It's it's when the bone marrow overproduces red blood cells and it promotes that hypercoagulable state. So promotes blood clots. Definitely need to rule this out because that patient will need lifelong treatment. So if you see an elevated red blood cell count, you want to make sure you further investigate. You don't ignore it, because even if it's things that are not as acute, like sleep apnea, smoking, you want to talk about smoking cessation with your patients, treat the sleep apnea. Maybe they need to change their blood pressure medication. You definitely want to make sure you don't ignore an elevated red blood cell count. Okay, so jumping into infectious diseases, first one I want to start off with is tuberculosis. And so with TB, we want to talk about why do we care about TB? So most of you, because you're all nurses, you've all had a TB test. So why do they care about TB? What's the big deal? Let's talk a little bit about which bacterial infection it is and how it spreads, and then what organ systems are affected. So the pathogen for TB is a Mycobacterium tuberculosis. So this bacteria has a waxy coating and it's very resilient against both environment and time. So it can live on most surfaces for months, which is pretty, it's not great. And it spreads through droplets, and it mostly affects the lungs. So the nice thing about TB is that it's not as infectious as, like, say, the flu, but it does live on surfaces. So we do want to definitely screen certain patient populations, and we'll talk about that. And we want to make sure that we're treating both active and latent TB, and we'll talk a little bit about that too. So which patient populations are we screening? So definitely patients who are immunocompromised or immunosuppressed. We want to make sure that we're screening them and they don't have latent TB that could turn into active TB, right? And so densely populated areas, remember we talked about the bacteria lives on surfaces for a long time. So patients who are incarcerated or living in areas that are densely populated, you want to make sure you're screening so that they do not have a latent or even active infection that goes unnoticed. And then in our older population and patients smoking, illicit drug use, those are our patients that are going to be at higher risk and we want to screen for. What you're going to see with the symptoms, so in active TB, you're going to see that blood-tinged sputum. It's one of the telltale signs. But the other symptoms for TB is more mild with the fever, night sweats. You might see some weight loss. So those are the pretty classic symptoms of TB. You've probably asked your patients about it or been asked those questions when you're getting your TB test done. So let's talk a little bit about latent TB. So latent TB lies dormant in the body, and we need to treat it to prevent potential conversion to active TB and prevent the spread of the bacteria and disease to others, right? So especially being in healthcare, we want to make sure that we are not carrying latent TB so that it doesn't become active for our own health and also our patients' health who are more immunocompromised or at risk with their deficient immune systems being down. So we definitely, as nurses, get our PPD tests pretty frequently. And then we also want to make sure that certain patient populations also get tested or screened pretty frequently. So the PPD is probably what you're more familiar with because that's what's happened for you in the past. With the PPD results, they come back in 48 to 72 hours, and the induration for a positive PPD is based on the risk factor. So you can see with someone with HIV, we have a pretty low threshold. Patients who are at higher risk, so if they come from high prevalent places or if they live in certain situations, also the threshold is a little bit lower. And then for everybody else, if they don't really have a risk of having active or latent TB, the threshold is a little bit looser. So it really depends. There's a whole algorithm, and you can rule in or out your patient based on their risk factors. And then if you do have a patient who can't come back for a PPD, you can always order that quantiferon gold test. So that's another test to help us diagnose TB, and that's a little bit more sensitive. But just remember that patients who are born in countries with a BCG vaccine could have a positive PPD test. The BCG vaccine does exist in the US, so always ask a thorough history about whether the patient has had a BCG vaccine or not. That'll help you if you get a positive quantiferon test. But whether the PPD comes back positive or that quantiferon comes back positive, you're going to follow up with that chest X-ray to confirm whether TB is present. And then treatment. So the CDC has guidelines based on the patient demographic, but the goal of treatment, again, is to help prevent the spread, prevent latent from turning into active, and prevent liver failure. So we definitely want to, as our part, screen and then also help treat the patient. These medications have some pretty serious side effects, so you're going to need some help with treatment because they do need to come back in frequently to get lab values drawn and make sure that they're tolerating the medications well and they're adhering to the medication. So typically in clinics that I've worked in the past, we've had TB clinics because it's been a big refugee population. So those are the patients that needed a lot more support to make sure they were adhering to the treatment, especially for latent. It's kind of a harder sell because patients feel well and they think, well, why do I need to take this medication that's not making me feel well, right? So getting some help there is going to be beneficial to you, but just making sure that patients are adhering to their regimen and that they're clearing the infection, and then also educating patients on precautions of making sure they're avoiding sharing items like utensils, cups, personal items until they have completed the course. And then, of course, active TB has its own course, but again, the CDC guidelines are very specific about how to choose the right medication for your patient based on the demographics. So you want to refer to that in the clinic setting. So malaria. So why do we care about malaria, and when is that going to come back to you? So you might see patients coming in for travel vaccines, and then they might say, hey, do I need to take something for, I'm going to blah, blah, blah country, and I want to make sure I'm taking all the prophylaxis that's necessary. So how do you know when to provide prophylactic medication for malaria? The CDC has a travel advisory and a guideline called the Yellow Book, which is really helpful. So you can look up where the patient is traveling to, and it'll tell you what they may need for those regions. But basically, you'll see malaria. Mostly it's in the sub-Saharan Africa and the Southeast Asia, South America. So if they're traveling to those areas, either way, if they're coming in for travel vaccines and to talk about their travel upcoming trip, you want to refer to the Yellow Book. It's pretty comprehensive, but that's when you might need to know what to actually prescribe this patient and what they may need. The treatment does depend on the region that they're traveling to, the patient demographic, the duration of the trip. So you want to look at that Yellow Book, and it'll help guide you through all of that. But what you want to do is make sure the patient understands the risk that they're taking when they're traveling. And it's important to let them know that no chemo prophylaxis regimen guarantees complete protection, right, against malaria. So if they do develop fever either during or after their trip, that's a medical emergency. You want to make sure that they do either come back in to see you or go in to see another health professional during their trip so that they can rule out malaria and start treatment right away. One thing about malaria that you should be aware of and always have kind of in the back of your mind when a patient comes in is that it can, some variants are dormant for months to years later. So you definitely want to make sure if a patient has traveled to these areas with a high prevalence of malaria, that you always have it in the back of your differentials. And then if a patient's pregnant, you definitely want to encourage them to avoid traveling to areas where there's more malaria prevalence because that does cause risk to mom and baby. So you want to make sure they defer their trip until after delivery. And then for prolonged visits, you want to make sure they're adhering to their prophylaxis both during and after their trip. And it's safe to use for prolonged periods of time. They don't really know past 2 years, but say you have a patient coming in and they're going to be doing the Peace Corps, you definitely are safe to give the patient the medication. And you want to make sure that you're supplying them with the medication. They're not buying it abroad because there are a lot of issues with the quality that they get in some of these other countries. So you want to make sure that they're picking up the prescription and taking it with them. Some other signs and symptoms of malaria. So we talked about that fever definitely should be a red flag. They might also have some headache, malaise, cough, nausea, vomiting, diarrhea, abdominal pain. So some pretty vague symptoms. It's really that fever that should be kind of a red flag for you. I also wanted to point out that some of these are contraindicated in pregnancy, and you want to look at those when you're prescribing as well. And then again, it depends on the region that they're traveling to, but some areas we have seen the chloroquine resistance. So that will help you determine which medication you're giving this patient, and the rate and frequency of taking the medication will also help you determine that too. But prevention is key. So you want to make sure, in addition to prescribing medication, you're educating the patient about making sure they're wearing proper clothing to protect their skin against the mosquito bites. They're taking with them DEET, insect repellent. That's going to be really helpful. If they're sleeping outdoors, if they're military, they're going to be at more increased risk. So making sure they have the right bed netting. Ideally, if they're sleeping in air-conditioned rooms, that's going to be better. But making sure you're doing your part by educating those patients on reducing their risk of contracting malaria is going to be helpful. So we talked a little bit about the infection. The incubation period is about 8 to 40 days. And again, why do we care about treating malaria? Because if it's left untreated, it can be life-threatening. So again, if they develop that fever either during or after their trip, that is definitely something you want to work up immediately. It's a medical emergency, and you want to make sure that it doesn't lead to something more life-threatening. And so the treatment is going to be happening more acutely. You're not going to be treating it once that patient has contracted malaria, but for you, you might be doing more prophylactic care and education for prevention, right? So HIV, let's go to our next slide. So everyone's probably familiar with HIV, but what do we need to tell our patients and what do we need to look for in our patients? So HIV is a virus that attacks the body's immune system, specifically the white blood cell count, that CD4 count. That's why we look at the CD4 cells and count. And how does it work? So the white blood cell count, the white blood cells are attacked by that HIV virus, and the HIV DNA actually works its way into the human DNA, and that's how it can lie undetected for so many years. So patients might feel really well for a really long time, and if you're not screening them, then they're going to progress and get sicker and advance through the stages, and we'll talk a little bit about the stages of HIV as well. But patients at high risk for HIV can develop and acquire other infections or diseases. So we definitely want to make sure we screen and treat to not only help our patients not advance in the stages, but also prevent the spread of the infection to the disease to others. So some risk factors. So you may already remember or know, but HIVs pass through bodily fluids. So I say bodily fluids because semen, vaginal fluids, blood, so all bodily fluids is going to be really important. And gonorrhea is the most common STI in patients with HIV. So if you're seeing a patient coming in with frequent STIs, so gonorrhea, chlamydia, and you haven't already screened them from HIV, you want to definitely have that conversation with that patient. We also, patients are at more increased risk who have men who have sex with men are also at more increased risk for developing HIV. And then also just any patient who's having anal or vaginal sex and having multiple sex partners. If you have a patient who is a drug user, needle sharing is definitely an increased risk factor. And then also it can be passed from mom to fetus or baby. So you definitely, if you are seeing that patient population, if you're taking care of our pregnant patients, you want to follow the ACOG guidelines for screening and treatment because it can be passed not only through fetus, vaginal birth, but also breastfeeding. Some of the symptoms that you may or may not see, like I said, it's kind of quiet for a little while until it gets really bad. So some of the symptoms you might see in general URI symptoms, fatigue, swollen lymph nodes. We call that acute retroviral syndrome, ARS. And then over time, you're going to see more thrush, that oral hairy leukoplakia you might notice, or if somebody's coming in getting frequent shingles infections and they're young, definitely want to think about their immune system and why is their immune system so compromised. So ruling out HIV. And then AIDS is when the disease has progressed and advanced. So you're going to see a lot more co-infections, recurrent pneumonia, bacterial infections, skin lesions, and then, of course, cancers. So there'll be a more increased risk for cervical cancers, lymphomas, and that Kaposi sarcoma is pretty telltale for AIDS as well. So screening, who do we screen? We screen all patients at least once, so between ages of 13 to 65. And then groups that you may want to consider rescreening are your high-risk groups. So again, men who have sex with men, if they have new partners, they've had exposure to a partner that they didn't know their status, you want to definitely make sure you're screening those patients more frequently, anywhere between every 3 to 6 months. Again, in our needle sharing population, or if the patients had multiple STIs, pregnancy, that's the ACOG guidelines, that's a whole protocol, but definitely we'll be screening in pregnancy. And of course, with multiple sex partners, we talked about that. So in our high risk groups, depending on the patient, you want to make sure you're rescreening those patients. The lab values that you may want to order. So how do we screen, right? So antibody tests like the ELISA are going to be our screening. So if that's positive, you want to always confirm that with the Western blot. When used in combination, the test is accurate at about 99.9% of the time. So that's a really good way to make sure you're catching those patients early. And then our CD4 count is what determines our staging. So if you look at the different staging in a normal, healthy individual, the CD4 count is between 500 to 1200. And then we have stages 1 through 4 for HIV. So you've had a positive ELISA, you confirmed it with the Western blot. What do we do now? We get that CD4 count and we stage it, right? So our goal is try to keep that CD4 count up. So that is our goal for treatment. And you'll notice between the stages, stage 1, stage 2, that patient's pretty asymptomatic still, right? Even when that CD4 count drops below 500, they might have some mild symptoms, but they're still going to be pretty asymptomatic. And then once we get to stage 3, once that CD4 count drops below 350, they're going to start feeling some symptoms. Maybe they'll have some chronic infections that you'll see. And then stage 4 is how we classify AIDS. That CD4 count is below 200. And then again, that classical Kaposi sarcoma is what we're going to see. But definitely want to make sure we're catching patients early on to help them delay that progression in the stages and severity. So what are the different types of treatments? So antivirals, antiretrovirals, they help by disrupting that viral replication. So it stops that virus from progressing and causing further damage. And the way we abbreviate is called heart therapy. Those are the different options. So you probably have heard about that. What is the goal of heart therapy? So the goal is to basically achieve undetectable viral load. And we measure that again with that CD4 count. So we are trying to keep that CD4 count above 500. That's how we classify that as undetectable and help prevent transmission. In patients who know they have HIV or have multiple sex partners where they don't know their status, there are different options. So we have pre-exposure prophylaxis. This is good for individuals, high-risk individuals that may be having multiple sex partners and they don't know the status and they're doing some risky behavior. You probably want to talk to them a little bit about PrEP. The abbreviation for this is PrEP. There's also post-exposure prophylaxis called PEP. So PrEP and PEP, so pre-exposure and post-exposure. The medications are the same, but the duration, the frequency is a little bit different. But you want to be thinking about these medications in patients who are having sex with men, multiple sex partners, drug users, basically at high risk, those high-risk individuals we talked about. Because the goal is we want to prevent them from contracting HIV, and then we also want to prevent the transmission to others if they have contracted it and they're passing it on to other people. So post-exposure prophylaxis might also be a good idea for, you've probably heard it in the nursing world. If you had a needle stick, we all know how unnerving that is. But want to be thinking about that in your population if they've had a sexual encounter and they're worried that they might be at risk. Maybe they knew the patient was HIV positive and they had unprotected sex. So 2 options you want to talk to your patients about and be thinking about. So Hep B is our big topic, and I left that for last so that we can ask all the questions we want about it, but we're going to really dive into Hep B because you're going to see it on the boards, and you definitely want to be thinking about this in clinic too with your patient population. And with Hep B, why do we care about hepatitis B? So a couple of statistics I wanted to bring to your attention, and that way you can kind of think about, well, maybe I should be screening my patients for Hep B and why it's so important. So approximately 2 million people worldwide have evidence of past or present hepatitis B infection. And of that number, almost 300 million people are chronic carriers. And in the US, it's about 880,000 people living with chronic Hep B, and they don't even know it. And studies have estimated that number can actually be closer to 2.2 million people if you account for all the immigrants coming from endemic countries. So Hep B is definitely something we should be having in the top of our mind when we're seeing our patients and we're caring for our patients. Screening can help lead to vaccinating the patients who have not been vaccinated, and it can also help treat those patients that are at risk for reactivation of infections that have resolved. It can also lead to reduction of liver cirrhosis and hepatic decompensation, mortality, and more specifically, hepatocellular carcinoma, HCC. So we want to definitely prevent liver complications by screening our patients early and treating those patients who are eligible. So the CDC classifies hepatitis B as a vaccine preventable liver infection caused by the Hep B virus. So our job in primary care is to help screen those patients, catch the patients that are needing treatment, and also vaccinate the patients who have not been vaccinated and are unprotected, right? So that's going to be our main job in primary care. So screening guidelines, the CDC just recently, back in 2023, adopted universal screening for hepatitis B. Kind of is crazy, but there's been a lot of changes in serology availability just in the last couple of decades for hepatitis B. And mostly because the CDC has noticed the low vaccination rates among adults and all the complications that are coming from hepatitis B virus. So who do we screen? It's universal screening across the board according to the CDC. So you want to make sure you screen all adults at least once. When do you repeat screening? So if a patient is not at risk for developing Hep B, you don't need to rescreen. But we're definitely going to talk about those patients that we're going to be thinking about rescreening because they're doing things that may be putting them at risk for developing or contracting hepatitis B. But at least once in all adults over 18. And then who are you rescreening? So Definitely pregnant patients, at least in the first trimester, we want to catch those patients early. They do a hepatitis B screening on all body fluid donations. And then also any patients, if you work in specialty, if you're starting a patient on immunosuppressive therapy like biologics, chemo, you're going to be checking for Hep B as well, just to make sure they don't have a chronic infection that hasn't been treated that's going to maybe get reactivated once their immune system is down. And then if you listen to my pediatric talk, you'll know that we offer vaccinations to everyone starting at birth. So under 6 months, you've already had 3 doses of Hep B in the United States. So we begin the vaccination process within 24 hours after birth. So these are the patients we're going to be screening. Who do we re-screen? So who are our at-risk patient population? So patients born in countries with a high prevalence of Hep B. So think about that immigrant population again. Persons with HIV or Hep C are at increased risk, drug users, men who have sex with men, multiple sex partners, history of STIs, incarcerated settings. So it kind of sounds familiar, right? Same risk factors as HIV. And then also in a patient that you're seeing elevated LFTs, or if they have liver disease, you want to make sure they've at least had one Hep B screening, and then you're re-screening them to make sure it's not chronic Hep B, and you're not missing that. So before we get into the serology, I have some terminology that I wanted to review with you, because the serology is not gonna make sense if you don't understand the terminology. And I want you to take a picture of the slide and try to think about it. I have another slide next that you can use for when you're going through your practice exam questions. It's gonna be really helpful too. But just some general terminology. So antigen, remember the antigen is from the viral protein. So the antigen is gonna be sitting on the outside of that virus. And then your antibody is your body's way of defending itself against that antigen. So it's what your body produces to help identify and fight that antigen. So antigen and antibody, know the difference between them. Different types of antigens in Hep B versus different types of antibodies in Hep B that you want to get familiar with, because that's what you're going to be ordering and evaluating once you get the lab results back. That surface antigen, so your Hep B surface antigen, that's again the viral protein. So the Hep B surface antigen is also what's getting injected in the person when they get a Hep B vaccine. So that can be positive in someone who has an active Hep B virus infection, or someone who's just been recently vaccinated. So that's going to be your surface antigen. You also have the E antigen, so the Hep B E antigen. The E antigen is released when the virus is replicating. So that's going to be more relevant to you if you have some positive markers that come back once you do your screening. And we'll talk a little bit about that. And you also have your core antigen. That's not something that can be tested in the blood, so it's not something that we order. So you don't have to worry about it, but it'll be relevant when we're talking about the antibody, core antibody. So that's your core antigen, and then there's your core antibody. So then let's talk about the antibodies. So you have your surface antibody. So again, patient either contracts hepatitis B, they develop the surface antibody, meaning that their body has developed antibodies against that antigen to help protect it, or the patient receives the vaccine, the surface antigen, and then again, their body develops antibodies to help protect against the virus. So the E antibody means that the virus has stopped replicating and you've had a good immune response, and that's going to be in patients who have contracted hepatitis B. And then you have your core antibody, which also can determine whether you have an acute infection, a past infection, or chronic hepatitis B. You also have your hepatitis B DNA, which we'll look at viral load. So we'll talk a little bit about when you would be ordering that as well. And then IgM, so that's going to be in your core antibodies. And so the IgM is for acute infections if it's positive, and your IgG can indicate either past or chronic infections. And so with IgM, think M for right this minute, this person is infected, and then think G for gone, or like past infections, or it could be in your chronic patient. And then chronic hepatitis B, how is that defined? So you have to have a positive Hep B surface antigen persistently for more than 6 months. And so your hepatitis B core antibody is also positive, but your IgM is negative. So it's not an acute infection, but it's a positive for chronic infection. So screening, what do you need to order in your screening test? So you want to definitely order the hepatitis B surface antigen. And again, asking history is going to be really important, making sure that patient hasn't recently been vaccinated, because that will obviously come back positive as well. But you're going to order your surface antigen. You're going to order your surface antibody to see if they've developed immunity. And then you're also going to order your total Hep B core antibody to figure out if this is positive, is it an acute infection? Is it a past infection that's cleared? Is it a chronic infection? So these are the 3 tests that you're going to be ordering for your screening. Okay. So that was a lot of terminology. I want you to take a picture of this slide as well, because this is going to help you determine what you're looking at when you're trying to interpret your serology labs. Again, this is on the CDC website, so you can always refer to this when you've ordered your labs. You're mostly going to need to know which labs are you ordering and what patients are you screening. And then this you'll refer to probably every time for a while, just to make sure, okay, is this a patient with an acute infection, chronic, past infection? They're now protected, so you'll be able to refer to this both in clinic and not something that's really going to be what you need to memorize in the boards. But I want you to understand it. So again, understanding these different terminology is going to help you remember what it's indicating. So in a patient, we're going to go through this really line by line. So in a patient with that Hep B surface antigen, if it's negative, but they have a Hep B surface antibody, meaning they've developed antibodies for that surface antigen, then they're immune by the vaccine because that core antibody is also negative. So that's indicating the vaccine has helped them develop immunity. You have a patient with a negative surface antigen, so nothing acutely happening, negative surface antibody, so they're not yet protected, and also negative core antibody, so they've not been exposed. So that patient is susceptible, and you're going to need to start the vaccine series in this patient. So this is really good because you want to identify these patients to help protect them before they do get exposed to hepatitis B. And then you have this patient, it's a negative surface antigen, so nothing acutely happening. Their antibody, the surface antibody is positive, so they are protected, and their antibody, their core antibody is also positive. So meaning that they have had an infection in the past, and so they have developed immunity to it. There's nothing acutely going on here, so immunity for a past, due to a past infection. And then if you have a patient with positive surface antigens, right? So something we want to figure out, is there something acutely happening? Is this chronic? Is this in the past? We need to worry about it. So positive surface antigens, the antibody, the surface antibody is negative in both, so they are not protected yet. You want to check that core antibody. It's probably going to be positive. Once you check that, then you can order your IgM and IgG to figure out, is this acute or chronic, right? So again, at PCP, our job is to screen, vaccinate, and get those patients who may have chronic Hep B to the right specialist to talk about their treatment options to see if they're eligible. So our first line is going to be screening and prevention. So let's go over a couple of case studies before we open it up to our Q&A. You guys have been super patient, so I really appreciate that. It was a lot of dense material to get through. So let's read Mr. Atkins' case study and see what you think and what your thoughts are. We could chat a little about it in the chat box. But so Mr. Atkins has an elevated LFT. So you've done your normal labs, CBC, chem panel, and you notice that they have elevated liver enzymes. We want to further investigate what that means. So we ask more history questions and find that he's never been vaccinated for hepatitis B. He denies ever noticing yellowing of his eyes. He's got no symptoms. Maybe he had a bad case of the flu about 3 years ago, but he's otherwise feeling well today. So it says, however, he has not been ill since. So he hasn't really been sick since 3 years ago after having a bad case of the flu. What would be our next action? So what would you be ordering for this patient with elevated liver enzymes? And you're suspecting, you want to see what does their hepatitis B panel look like. So what are you going to order? And again, I don't want you to be nervous about answering in the chat box today. Today is the day to get it wrong so that we can talk it through, right? So are you ordering a liver ultrasound? Are you ordering the hepatitis B surface antigen, the surface antibody? Are you ordering the core antibody, IgM antibody? What are we ordering? Awesome. So I'm seeing some feedback from the chat. Good. So I'm seeing a lot of B, C, and D, B, C, and D, C, and D. So you guys are right. The answer is A, B, C, and D, and we'll talk a little bit about that. So in a patient, what I want to point out with this exam question is in a patient with elevated LFTs, the gold standard is to order that liver ultrasound because you want to see if there's been any damage to the liver, if there's any cirrhosis, fatty liver, anything going on, why are those LFTs elevated? And then you also want to think about hepatitis because he's never been vaccinated for hepatitis. So yes, you would be ordering the surface antigen as well as the surface antibody just to see if there's any protection or active infection. And then you also want to see the core antibody to see if he's been exposed and cleared it in the past. So absolutely right, A, B, C, and D. Very good. Okay. So you've ordered that liver ultrasound and that's come back normal. The surface antigen is negative and the surface antibody is positive. So what does that mean? That means, and then his core antibody is also positive. So that means that he's been exposed and he's cleared the infection in the past, and now he's developed antibodies to it, and there's nothing acutely going on. So in this case scenario, because his liver ultrasound was normal and he's also developed antibodies, there's no further action that needs to happen. So he is good. He is protected. So in Miss Elena, she's an exchange student from Mexico studying to be a teacher in the US. She's asking you to draw her titers as she's unsure what she's been vaccinated for in the past. And she wants to know if she's up to date on her vaccines before she takes care of her kiddos in the classroom. So what do you draw on Miss Elena? What are going to be your screening labs? Go ahead and put that in the chat box. Okay, so I see some responses. You guys are getting it right. So this Hep B surface antigen, absolutely. Also the Hep B surface antibody to see if there's been protection, right? And then the total core antibody, Hep B antibody. So absolutely, you want to evaluate all three of those. Those are going to be your screening labs that you're going to order in this patient. Very good. And then last question, you're working in the urgent care clinic. Miss Angelo, 27-year-old female, comes in. She's complaining of nausea and stomach aches. You order a CBC chem panel and pregnancy test. And what do you see? Her LFTs are elevated. So AST is 82, ALT is 97. So what are you going to go ahead and order? So you go ahead and have the lab run the Hep B panel just to make sure nothing's going on there. And the results are as follows. Her pregnancy test is negative. Her Hep B surface antigen is positive. Her surface antibody is negative, so there's no protection there. And then her core antibody is positive. So we see a positive surface antigen and a positive core antibody and a negative surface antibody. So what are we going to do next for this patient? Yes, awesome job, you guys. So you definitely want to rule out active infection, right? So you're going to order the IgM antibody, that core IgM, just to see if it's active infection that we need to treat. And remember, if it's an active infection, the treatment will be supportive care for that phase, but you're going to get them to the right referral specialist to make sure that they're managing this patient and to prevent developing into chronic infection. All right. So I know that was a lot of material. You guys did a great job. I love the interaction, and you guys are going to do awesome on the boards. As always, we have these webinars that are free to you that bring you all the information and great practice questions that you need to help prepare for your boards. We also have a 3-day live review coming up at the end of May that we'd love for you guys to join us on. Even if you can't join for the live days, you get access to the recordings for 30 days. Registration is just $50 for all 3 days. So if you sign up, you'll get the recordings for 30 days, even if you can't actually be there in person for the actual live review. But if you can join us in person, you can ask any questions you have about the topics that we're presenting on, or any questions you have about Archer or just the boards in general, and we'll definitely be able to help support you. And then, as always, our question bank is available to you for free. There's a free 30-day trial. We're getting a lot of great feedback about our question bank being really comprehensive and helping people pass the board. So we're really proud of it. We have over 1,500 questions, and we come up with new questions every week. So definitely check that out, and you can if you like the free trial and you have a little bit of time before your boards, you can sign up for the 60-day access. And like I said, it's over 1,500 questions, and we're getting a lot of good feedback about the rationales. And what I recommend is just doing practice exam questions, because you learn a lot from the rationales, and it'll help you prepare for your boards. And then, as always, follow us on social media. Last week, we gave away a lot of goodies for Nursing Week, Nurses Appreciation Week. So social media is a great way to follow us to figure out what's coming up next for our reviews, whether it's the live free reviews or our 3-day webinar, our 3-day live review. And then you can always email us with any questions you have directly to our FNP email, and somebody will get back to you. But we're here for you, whether you're just wrapping up school and you haven't even thought about starting for the boards, or you're getting ready, you have a date and you need a study plan. We have a lot of good things, and our goal is to basically get you the support you need at the most affordable rates possible. So definitely check us out on all the different great things that we're doing. Our product is expanding, and we're getting a lot of good feedback about those Q banks and our live reviews. So now I'm going to open it up to questions with just 5 minutes left. And if you need to hop off, that's okay. Thank you so much for joining me today. I really appreciate your listening and engaging. That's always awesome. And it's great to see some familiar names and faces. But this is your time to ask any questions you have, whether it's about lab review and infectious disease, or if it's anything Archer. Just go ahead and ask your questions in your chat box, and we'll get them answered for you today. That's great, Christina. We're excited to see you in our 3-day live review. So I have a question about the last case. Would you offer a liver ultrasound? Let's go to that last case again. So in this patient, so the first thing you want to do is order that IgM. So first you want to make sure if this is active or not. But with the increased LFTs, yes, you would still be offering liver ultrasound. That's a gold standard. It's a great question. Absolutely. Yeah, thanks, Anissa, for the question. Anybody else with any other questions? And remember, it could be about anything. It doesn't have to be about today's topic. It could be about our products, what's available for you. We also have tutoring coming up. We'll have some sessions open up after our live 3-day review with our presenters, including myself. So there'll be some one-on-one tutoring sessions you can sign up for. Eventually, we'll have some small group tutoring sessions too. So if you want to do it with a couple of friends from your program, but it's all really affordable. And I wish it was this resource I had when I was coming out of school and preparing for my boards, because the prices are great and the material is really robust. So we're getting a lot of feedback that students are seeing what they're practicing in our Q bank come up on the board. So we definitely take pride in making sure the quality is there for our product. And we'd love to hear your feedback as you're going through the Q bank and just all our presentations. Don't be shy, ask the questions. All right, you guys, if there aren't any other questions, I'm going to go ahead and wrap up the webinar for today. Thank you again for joining me. I really enjoyed talking to you guys. And if you have any questions, please reach out. We are here for you, and we'll see you at our next webinar. Thank you so much for joining us today.